This afternoon we are going to talk about monitoring patients who are on treatment. So if you remember our first gentleman, the 67-year-old man who was referred after a fragility fracture of the hip, and you probably remember from the last session, the recommendation was to start him on zoledronic acid, and the main reason for choosing zoledronic acid was that he had GERD, was on omeprazole, so we couldn't give the oral bisphosphonates, and he travels a lot, so an annual infusion fits in very, very well with his lifestyle. We also recommended that he discontinues zolpidem. We recommended that he maintain an adequate daily calcium and vitamin D intake and to maintain his physically active lifestyle. Now 5 years have gone by. He's had 4 reclass or zoledronic acid infusions, each one 5 milligrams, hadn't experienced any adverse effect. He has stopped zolpidem and he's on no other medication except for the omeprazole. And his bone mineral density has increased over the past 5 years by 7% in the lumbar vertebrae, 6% in the total hip, 5% in the femur and neck. And now the T-score, lowest T-score is minus 1.8. As you can see earlier, it was minus 2.7. So even though we don't like to compare the T-score when we monitor the patient's response, we like to look at the BMD. There have been increases in the BMD, and the T-score is minus 2.8. So the question now that we need to address are the observed changes in bone mineral density, the plus 7% in the lumbar vertebrae, the plus 6% in the total hip, the plus 5% in the femur neck, are these statistically significant? Are they clinically significant? Or, given the available data, their significance cannot be ascertained. And option D is A and B, they are clinically and statistically significant. Many undecided people. I hope you had a good lunch. So the majority seem to think that these changes are statistically and clinically significant. I'm afraid I've got bad news for you. We cannot really tell whether these changes are significant or not because we do not know what is the least significant change in the center where the DEXA scans were done. And it's very important to know what is the least significant change because it may happen that the technologists there are poorly trained, or it may happen that for whatever reason the patient was not properly scanned, was not put in the ideal position to be scanned. The original baseline 5 years ago and now are totally different, and you cannot compare them. And this is why we cannot make any judgment whether or not any change, even changes that appear to be large enough, we cannot pass judgment that they are significant or not significant without knowing what is the least significant change for that particular center. And the way it's done, the technologist would put the patient on the table, position her, scan her, ask the patient to get off the table, and then go back on the table and scan her again. And you can do this on 15 patients 3 times or on 30 patients twice. And then you go onto the website of the International Society of Clinical Densitometry, ISCD, and there is an application where you can calculate the least significant change. And they ask you to input the data of these 30 patients, the 2 scans that were done, and then they tell you what the least significant change is for that particular technologist in this particular center. Once you know what is the least significant change, then you can judge that the observed change is clinically significant or statistically significant. Did I make myself clear? This is very, very important because we see more and more patients being scanned sometimes once on the hologic, next time on the lunar. You cannot compare them. We talked this morning about the femoral neck, that anatomically we're looking at different areas. The technician may not have enough experience to position the patient in exactly the same position, and this is why the patient needs to get off the table and placed back on the table to calculate in the hands of this technologist at this particular center what is the least significant. Because if the observed change is less than the least significant change, it doesn't matter how big it is. If it is less than the significant change, then it could be just due to chance, due to the positioning of the patient. And it's very important to ensure that the technologist actually moves the patient off the table and then go back, because I saw it. The technician says, oh yeah, there are the results, and you look at the results, they're almost identical. First scan, second scan. And then question asked, did you really get the patient off the table? And she blushed and said, well, I didn't want to make the patient uncomfortable. Nothing to do with the patient being comfortable or uncomfortable. You want to know what is the best that technologists can do. Yes, sir.
Do you report for each individual technologist the least significant change, or as a facility?
Okay, if you have only one technologist, it's easy. If you have more than one technologist, you can either look at the average, or better still, you look at the least significant change for each technologist. So you can do it several ways. You can either calculate the least significant change once a year, what many of us do, and I'll be very interested, Sandy, to know what you're doing. But what we do is every Wednesday, the very first patient that comes is part of that precision study to calculate the least significant change. So we have an ongoing program, and once we finish with 30, we get the 31st and drop the first, and we continue. So it becomes a sort of routine for that patient. But technically, yeah, you need to know what is the precision or the least significant change for each technologist. Sandy?
Sure. What we do is whenever there's a change in the validity or accuracy of the analysis, positioning, whatever we find, then it's time to reassess the technologist's cumin. And we repeat their educational program. We do a repeat precision error after that, and we're then assured that we're performing the correct, valid positioning and analysis of the patients. We do a rolling precision assessment, as Ron had stated, but not every Monday. It's like once a month. We replace one of the inputs with a totally new patient, and that's what we do.
Thank you. So the correct answer to this is that given the available data, the significance cannot be ascertained. A question that often arises is, when we write the report, would we say these are the observed changes and the least significant change in our center is such and such? And I personally do not. If the least significant change is less, if the observed change is less than the least significant change, I would just say there is no significant change. I don't give data because it has happened that, let's say you pick up a change of 3.5% or maybe 4%, and your least significant change is, no, let me do it the other way. You pick a change that is 2%, and your least significant change is 4%, and you write in your report the observed change is 2%, but the least significant change is 4%, and it happened to me on a few occasions where the primary care physician says, well, I don't really care about HAMD is significant or not significant. 2% or 4% is significant enough for me, is good enough for my patient. He misses the point. The point is, if it is less than significant change, you cannot say it is significant or not. So to avoid all this hassle, I would say it's not significant. Do you agree with me?
Mm-hmm. I don't even comment on the change per se. I just say if it's statistically significant or not.
Okay, so let's move on to the next question. And the next question is about least significant change. Is it a quality assurance exercise? Is it a research program? Is it calculated by the manufacturers and the information is available in the handbook? Does it require approval from the institutional review body or other ethics committee? And E is A and C. Would you like to cast your votes, please? So we seem to have a majority that it is a quality assurance program, and you're absolutely right, it is a quality assurance program. It is not a research program. However, it is very wise to get informed consent from the patients to say that they're going to participate in a quality assurance program to determine the least significant change. It's also a good idea to let the IRB or other ethics committee know that this is what is being done. But the way people look at it now, it is not a research program. You do not need to submit it as a research program, but it's still wise to make sure the IRB knows about it and the patient has signed. So the next question is, the least significant change determines whether the observed change in BMD is significant. Should it be calculated for each center and each technologist? Is no longer necessary with modern densitometers. And we've already covered this, so it shouldn't be too difficult. And you're absolutely right. It should be calculated for each center, each technologist, and it determines whether the observed change is clinically significant. Now, the manufacturers give you what is called the precision as a percentage. This doesn't tell you how good your technologist is, and it doesn't tell you what the least significant change is. The other thing that I forgot to mention is that when a precision study is done, it should be done on people who are representative of the population that is being scanned. For instance, if most of your patients are over the age of 70, it doesn't make sense at all to do the precision studies on medical students or technologists because they're not representative of the population you actually scan. Okay, let's move on. The least significant change is calculated by scanning several patients 2 or 3 times after asking them to get off the densitometer table and repositioning them. Is a measure of the technologist's expertise at accurately repositioning the patient and can be calculated by inputting the data in a spreadsheet on the IACD website. We've already addressed this, so it should be fairly straightforward, and your many undecided people, okay? Okay, and the correct answer is E. D is partly correct, but A is also correct. It's calculated by scanning several patients 2 or 3 times and getting them off the table and repositioning them. Okay, let's move on. The next one is, when calculating the least significant change, the patients included in the program must be similar to the majority of patients scanned in the center where the DEXAs are done. The subjects included could be young, healthy volunteers working in the office. The patients must sign an informed consent form. And it's a tricky question. Okay, I said it's a tricky question because of this word here, must. It is preferable if the patient signed the informed consent, but technically they're not obligated to sign it. It would be better if they do, but if you just take a verbal informed consent documented in the patient's record, this should satisfy the criteria. We have already spoken about the subjects should be similar to the ones that are scanned, and so they could not be young, healthy volunteers if most of the scans are done on older people. Any questions so far? I'm spending a lot of time on the least significant change because if you don't know the least significant change, there is no way you can monitor the patients. And this whole section is about monitoring, and this is a clue factor because this will tell you whether the patient is responding to your treatment or not responding to your treatment by being able to notice the changes in BMD and confidently say, yeah, these are significant changes. So, next question. When fine-tuning the management strategy in patients on anti-resorptive medication for more than 2 years, the following should be considered. Do you look at the changes in BMD? Do you look at the T-scores? Do you look at the fracture risk? Or do you look at the three? And again, this is a trick question. I knew it was coming after lunch, so we've got a few trick questions today. So we look at the changes in BMD, and we look at these changes in the light of the least significant change. We also look at the T-score, but not the changes in the T-scores. The fracture risk, you need to look at it, but you cannot use the FRAX. In fact, the FRAX is to be used only in patients who are not being treated. Once you start treating the patients, the FRAX is no longer as useful. You still may want to use it, but it's not as useful. And when you think about it, the changes are not going to be that dramatic, especially if you don't use the BMD. But it's a good thing to monitor the fracture risk. For instance, if the patient now has had quite a few falls, or if the patient had a stroke, or if the patient diabetes is getting worse. So all this will help you evaluate the fracture risk. So this is why, it is, you should look at the fracture risk, but you cannot look at the FRAX score to help you with it. Okay, so let's go back to our patients. And if you remember, he's had 4 zoledronic acid infusions. We've got the increase in BMD. At this stage, should the zoledronic acid infusions be stopped? Oh, I didn't tell you, these changes exceed the least significant change. So now we know that these are significant changes. So now do you stop the zoledronic acid? Do you ensure an adequate calcium and vitamin D intake, preferably from food? And do you repeat the scan in 2 years' time? Or do you stop zoledronic acid and ensure enough calcium and vitamin D? Or do you do the 3 at the same time? You stop zoledronic acid, you make sure the patient is getting enough calcium and vitamin D, and you repeat the scan in 2 years' time. And the majority would vote to stop zoledronic acid, make sure the patient is getting enough calcium, vitamin D, and repeat the scan in 2 years' time. And I agree with this. Sandy, would you like to agree? Or?
I think the zoledronic acid data, can everyone hear me in the back? So the ZOL data, they looked at 3 years of ZOL and then placebo, or continued ZOL for 6 years, so a total of 6 years. That was the initial registration trial. So they extended it for 6 years, or half the population on treatment, they stopped. And they looked at the outcomes of these patients, and they found that unless you had vertebral fractures or were at high risk of vertebral fractures, there was no difference in non-vertebral fractures at 3 years versus 6 years of therapy. So if the patient is at high risk of vertebral fractures, then they did see a difference at the end of 6 years of therapy versus holding the therapy for the last 6 years of therapy. So I think that it depends upon the situation that you find yourself in with that patient and whether they've had additional fractures, they have additional risks, or they have had no further fracturing since the initial treatment of 3 years and no spine fractures.
So this particular patient did not sustain any more fractures during the period of treatment. The BMD went up significantly, and the T-score is lower than minus 2.5, and all these are grounds to say we're going to discontinue the medication. Patient had already 4, as opposed to in that trial when they looked at 3 years and 6 years. Yes, ma'am.
So if the patient, other than this patient, had a vertebral fracture, a prevalent one, but had no further since starting
again, you need to look at the whole context, the vertebral fractures, the changes in BMD, and the actual T-score. So if we take one extreme, the patient has sustained a couple of vertebral compression fractures, the BMD has not changed, and the T-score now, instead of being minus 1.8, is minus 3.2. Clearly, the patient has deteriorated. You really need to do something. To just continue zoledronic acid with this patient doesn't make any sense. You need to find out, is she vitamin D deficient? Has she got secondary osteoporosis? Is she not getting enough calcium, vitamin D in her diet, and so on? So you really need to evaluate her. If, on the other hand, you have a patient like this one, where there has been a significant increase in BMD, no fractures, T-score is lower than minus 2.5, you can feel reasonably confident it is a good opportunity to stop the medication, repeat the scan in a couple of years' time. You agree, Sandy?
I think that if the patient had increased risk of vertebral fractures, I would continue for a full 6 years. That's just my impression from the data.
Are we okay? Yes, ma'am.
From a diagnosis standpoint, but once osteoporotic, always osteoporotic, correct? So he was diagnosed with osteoporosis even though we have improvement or osteoporosis with improvement, correct?
Well, this is debatable. So the question is, once the diagnosis of osteoporosis is made, does the patient carry the diagnosis for life even though the patient is treated and BMD gets better and T-score gets better? Sandy, what do you think?
Well, the patient had a hip fracture. The patient has osteoporosis.
Right.
He's always going to have osteoporosis. Right. It's like an alcoholic.
Okay.
You know, this patient has a diagnosis of...
People start to say, well, now he's osteopenic.
No, you won't have your reimbursement for your Reclast or any other drug that you're going to be using in the future with him.
Yeah,
especially if the patient has already sustained a fragility fracture. Any other questions? Yes, sir.
If it was just by the DEXA that he was diagnosed with osteoporosis and then it went down, does he also stay osteoporotic for life?
I think it depends upon whether you're going to continue treatment. Remember, you're not going to be reimbursed from your tertiary players or Medicare if it's osteopenia. So what I use is osteoporosis. I mean, his bone density is osteopenia, but he responded to his medical therapy, assuring yourself that you did review the DEXA scans and that there was no artifacts, as we talked about, or other issues that we see as we age. There's very frequent, falsely increasing bone density at the spine. So the hips are pure sites in most cases to do serial comparisons. Because we see degenerative change in 80% of people, 80 and over. You know, it's so common that you have to be assured that there aren't other reasons for that BMD to be increasing at the lumbar spine. Assured that the patient doesn't have degenerative arthritis of the hips, or avascular necrosis of the hips, or something else going on at the hips, like Paget's or whatever, that's influencing your bone density. So you have to be sure that true change that Ron is pointing out is real.
Let me be the devil's advocate, and I'm going to push you, Sandy, a little bit. I know you well enough, so I can feel confident I can push you. Patient didn't sustain a fragility hip fracture and no vertebral fractures and no artifacts, no osteoarthritis, no avascular necrosis, no patches, no secondaries. And he's been treated with zoledronic acid, and he did very well because these changes exceed the least significant change. Now he comes for a follow-up visit, and he tells you, Doc, I don't have any insurance, but I'm very wealthy. I don't really care about medical expenses. Do I still have osteoporosis?
So number one, Ron can weave a great story. So let's just take a look at this patient. The patient has had an increase of 7% in BMD. He has had no primary events that we're monitoring, no new fractures. So this patient would be on a drug holiday. This patient is on a drug holiday. He's had a dramatic improvement in BMD. I would say, if I was reading the DEXA, I would say he has osteopenia at this time. If I was seeing the patient clinically, the patient has osteoporosis. That's why I treated him for 4 years. Okay? And that's in the chart. And that will always be in his chart. If you're using electronic medical records, it will always be in his chart, and I would never delete the diagnosis of osteoporosis.
The analogy I often make to my residents and fellows, it's a bit like the guy who's hypertensive or diabetic. So he comes with hypertension 5 years ago, you put him on hypotensive medication, and you see him a year or 2 or 3 or 5 years later, blood pressure is very well controlled. Do you remove the diagnosis of hypertension, or does the diagnosis stay? And the same thing for diabetics. So, and I think it's important to explain this in the notes that the patient had osteoporosis or densitometric evidence of osteoporosis. This evidence now has improved. He's responded very well to the treatment. But by the same token, that you do not change the diagnosis of hypertension if blood pressure is well controlled, or the diagnosis of diabetes. If diabetes is well controlled, the point you're making, once diagnosed as osteoporosis, the patient has osteoporosis, but this doesn't stop us from telling the patient that you really have improved quite a lot. Technically, you do not have osteoporosis, but I also sometimes make this analogy to the patient. If you were hypertensive, and the patient understands this, that once you have a diagnosis of hypertension, you carry it for the rest of your life. Now, it can become controlled hypertension, but we seldom in the records write controlled hypertension. We make the diagnosis of hypertension and say the present reading is 120/80. Fantastic. Hypertension is well controlled. But that patient had a history of hypertension. I feel it's important to maintain this, to let the patient know that, yeah, your osteoporosis is getting much better, but you're still very much at risk. And you must make sure, even if we stop the medication, you must make sure that you get enough calcium, enough vitamin D. And so you motivate the patient, you get them involved in the treatment process, and they're quite happy. And it's important, and we'll see as this session evolves, it's very important to make sure the patient is very much involved and takes ownership of the management program. And a change like this, with 7% increase in bone density of the lumbar vertebrae, is very good. Share it with the patient, congratulate him, pat him on the back, and say, keep up the good work. And now the good news is we're going to stop the medication for 2 years. And in 2 years' time, we're going to repeat the scan. Reason for repeating the scan is that you had osteoporosis, and we want to make sure that you don't relapse.
Yeah, it's a good way of thinking about malignancy.
About?
If the patient has a malignancy,
treat them.
Same
thing, yes.
It's no different. They're in remission for now, but they still have that diagnosis. And when we talk about drug holidays, it's a holiday. It's temporary. It's not permanent.
We'll talk more about drug holidays. I hate the term, but we'll talk more about this in a few minutes. Okay, so what are the take-home messages? They're in your handouts. No need to go over it. We've talked enough about this patient. Let's move on to case number 2, if there are no other discussions about this patient. Okay, so case number 2, you remember Mrs. B, she's the one who developed the vertebral compression fracture while watching TV. She has been given alendronate 70 milligrams once a week. It's now 8 weeks. So what we do, we just prescribed alendronate. And then 8 weeks later, from my office at least, there is a call made to the patient to ask how she's doing and is she taking the medication. And the lady says that the back pain has improved, has considerably subsided. She is taking the medication as directed, the bisphosphonate, oral bisphosphonate, is not experiencing any adverse effect and is happy to continue taking the medication. So pain has gotten better. She's taking the medication. It's now 8 weeks after the initial event. Should she be encouraged to continue taking the medication? Should you make inquiries as to whether she has maintained her daily calcium, vitamin D intake? And would you contact her again in 4 to 6 months' time to ensure that she is still taking the medication as directed? And your votes, please. Two more and we have a majority. One more. Okay, and we've got a majority. A majority of people agree that she should be encouraged to continue the medication, make sure she's getting enough calcium, vitamin D in her diet. And I personally find it pays a lot to have another phone call or another contact with the patient 4 to 6 months later, maybe 3 months, maybe 7 months. It doesn't matter, but in the future to have a contact with the patient. Again, don't forget you're asking the patient to alter her lifestyle, to take this medication, and you want her to continue complying and adhering to the medication. It's important to make her feel part of the decision-making process, that she buys into this concept. Otherwise, she's going to stop taking the medication. I don't like to increase the patient's medical bills unnecessarily, and this is why it's usually by phone calls as opposed to inviting the patients to come back to the clinic just for a chat and the checkup is not really worth it. But you really want to make sure that the patient has both the concept of taking this medication on a long-term basis, 2, 3, 4, 5 years or more. So these contacts are very important. Okay, let's move on to the next question. 4 months later, she is contacted by phone. She is taking the oral bisphosphonate as directed, is not experiencing adverse effects, is happy to continue taking the medication. Now we're 4 months after the 2 months, so all in all it's about 6 months. She should be encouraged to continue, inquire about calcium, vitamin D, another phone contact 4 to 6 months later. And we've got a majority, and I agree with the majority. I like to keep contact with my patients. I don't speak to the patients myself, but my nurse or the receptionist talks to the patient, and they say, yeah, I'm taking it, no problem. Yes, I'm getting enough calcium. Yeah, I look forward to hearing from you in a few months' time. It does ensure compliance. Sandy, anything you want to add?
I don't have a nurse that can help me. Could you please send
I can't spare my nurse. No, I can't spare
your nurse. What I do things maybe a little bit differently in that because I don't have someone else. I have the patient come back 6 months after initiation of therapy. I take my time. I discuss things with the patient and assure them that things are going according to what we had initially planned. But I also do biochemical markers and bone remodeling prior to institution of therapy, and then 6 months into therapy to be sure that there is effectiveness of therapy and an alternative surrogate marker other than BMD and fractures.
Are the patients reimbursed for that?
The markers that
they do?
I do, yes.
Okay.
So basically what I'm saying is if we see, for example, with a bisphosphonate, a significant reduction in biochemical marker bone remodeling rate, of a certain degree beyond the least significant change of the markers, then you can predict fracture risk reduction based on that published data. And then you're also assured that that oral bisphosphonate, like alendronate, is being absorbed also, because you're never totally assured that that patient's drug will be absorbed. So knowing that the drug is effective, that there is a substantial decrease in bone remodeling rates at 6 months, I can assure the patient that it's working, that there is likely to be fracture risk reduction, and I know it's being absorbed, and the patient, of course, is compliant then. Yes?
The only reservation I have about your approach is it's ideal. The only reservation I have is I had many insurance people denying it.
Right. It depends.
So the only time I use the bone markers is if I'm not sure the patient is going to comply with the treatment. And I'm sure you've come across many of these patients. Yes, doc, I'll take it. I promise I'll take the medication exactly as you tell me. And you're very suspicious that the minute she walks away, she's not going to take that medication. So this is when I would do the bone markers. But ideally, if the insurance repays for the 2 tests, because you need 2, you need the baseline and you need the other repeat 3 to 4 months later, and the patient should be fasting when the test is done. So if the insurance reimburses you, it's terrific, it's very good. My experience, very often they do not. And before doing it, I contact the insurance and say, I need to do it twice. Most of the time, they won't commit themselves to me. So the patient is left, and she may be footing a bill of where I work. It's about $120. I don't know how much they charge at your end for the bone markers. Yes, ma'am.
Other than the cost, do you have a particular one that you think is more reliable? The serum NTX, the urine NTX, or the CTX, which one?
The International Osteoporosis Foundation, the National Osteoporosis Foundation, most of the bone societies believe that the serum CTX and the bone-specific alk phos are excellent markers with the least variability. Urine NTX has a variability of about plus or minus 50%. The serum markers are about 30%. BSAP is not expensive, bone-specific alk phos, not isoenzyme, but bone-specific alk phos. That's not expensive at all. It's the serum CTX that could be expensive, like $100 or $120, something like that. Because I see significant non-adherence to therapy, and the published data supports me, and with patients that have significant fracture risk that I see in a tertiary care setting, I don't want to take a chance. So it's just my preferences, because I deal with a specific population that's at that it's high risk for future fracture. I do everything I can to assure compliance as well as reinforcement of the medical therapies, and I don't feel comfortable waiting 2 years for that repeat bone density test. And this is substantiated by publications showing that bone markers, this was a Rezedronate trial many years ago that I participated in, that there was increased compliance with feedback, not only BMD feedback, but also biochemical marker feedback.
And you're looking for a 30% or greater change?
Yes, at least. Now,
At least.
Now we have to understand that if you ask your laboratory what is their intra-individual variability of biochemical markers, it is doubtful they will have it. This is a problem. And also the IOF and the NOF and most of the organizations and societies and published papers on this have acknowledged. They have inter and intra-assay variability, which means they perform the study multiple times on the same machine or different machines with the same laboratory specimen. They do not do intra-individual variability testing. So meaning that the same patient done 2 or 3 times, just like DEXA, like Ron had mentioned in regard to a precision assessment, they do not characteristically do intra-individual variability testing. There are a few laboratories that do. So we're using best case scenario, the only thing we do have. So I would use at least the 30%. variability with serum markers. But then again, it's not 100%. I must emphasize that, because most of the laboratories do not do that.
Okay, let's move on. So now she comes a year later. She comes 2 years later. She had a DEXA scan done. It shows that the BMD of most of the bone scanned has increased significantly. That is more than the least significant change. And the lowest level of her T-score now is minus 2.6. She is taking the bisphosphonate as directed, is not experiencing any adverse effect, is happy to continue taking the medication. So she's done well. Her BMD has gone up. It has exceeded the least significant change. Her T-score at present is minus 2.6. At this stage, would you encourage her to continue taking the bisphosphonate? Would you stop the bisphosphonate and prescribe another anti-resorptive? And would you make inquiries about her calcium and vitamin D intake, or would you do this, or would you have different A and C and A, B, and C? And we've got consensus that she should be encouraged to continue bisphosphonate and to ask about, or to ensure that she's getting an adequate calcium and vitamin D intake. So she's 2 years during the treatment. She's responding well. BMD is going up. There should be no question at all. We need to continue, especially as her T-score is still quite low. Any question about this? Okay, let's move on. And now she comes 4 years later. And her DEXA scan shows that the BMD of all the bone scans continue to improve above the LSC. Her lowest T-score now is minus 2.3. She's taken the bisphosphonate as directed, no adverse effect, is happy to continue taking it. So we've had a continuous steady increase over the past 4 years. Now her lowest T-score is higher than minus 2.6. Would you encourage her to continue? Would you stop the bisphosphonate? Would you replace the bisphosphonate by another anti-resorptive? Would you stop the oral and prescribe IV? Or would you stop and give an osteoanabolic? That's close, very close. Gee. Any more coming? Both positions can be defended. I'm very interested to know what Dr. Boehm is going to do, and I'll tell you what I'm going to do in a minute. But essentially, both positions can be defended. She's a lady. She's been on oral bisphosphonates for 4 years, gradual increase in BMD, T-score minus 2.3. Dr. Boehm, what would you do?
What do you want to hear?
I'd prefer to hear what I'm not going to do so that we can have a meaningful discussion.
So this patient has severe osteoporosis, right? So she's had a spine fracture, and she has very
fragility
low fracture, and she also has very low BMD from the onset. So this is not a mild risk for future fracture. This patient's at high risk of future fracture. I would continue medical therapy.
Okay. Let me explore another slightly different scenario. She had never had a vertebral compression fracture. She was diagnosed based on her T-score of she had osteoporosis, a densitometric diagnosis. Let's say it was minus 2.8. Now it's gone up to minus 2.3. Would you continue, or would you?
I'd consider a drug holiday.
So you see the difference Okay, what would make you consider a drug holiday, even though the term holiday makes my, I hate that word. But so you consider discontinue the medication as opposed to continuing, because in this patient, not only did she have osteoporosis, she had osteoporosis, but she also sustained a fragility fracture. So you may make a point for continuing. On the other hand, if she did not have the fracture at all, and you estimate her fracture risk and you find that it's not really increased, you may be justified to say 4 years is enough, you've really done very well, let's stop for a couple of years, and then we'll monitor your position and see what is happening. In the meantime, because she's been 4 years on the bisphosphonate, it's likely that their action is going to be carried over for at least another year, probably 2 years, probably even longer. But you see the slight difference that the presence of a fragility fracture makes. Essentially, we agree, but every now and then we're going to disagree just to get the discussion moving. But you see how important it is to look at the whole patient, not only densitometric finding, but whether or not the patient has sustained a fragility fracture. Because remember what you were saying earlier this morning, once the patient sustains a fragility fracture, her risk of fractures anywhere is substantially increased. And you don't want to run the risk. She's done very well, so ideally you want to continue her improving if she had a fracture, and you don't want her to have another fracture. If she never had a fracture, it's a different kettle of fish, and you may be prudent to discontinue the bisphosphonate for a couple of years.
So I think I just want to reinforce that you have to look at the total picture and whether the patient has additional clinical risk factors for fracture that are not present, were not present at the initial visit and the initiation of medical therapy. If you're looking at the patient is 75 at the onset, not 70 years. You also have to think about age-related osteoporotic change, age-related fracture risk increasing also. You have to look at all clinical risk factors before you make the decision of whether you wish to discontinue medical therapy or not. That's the key issue.
Yes, sir.
Would you consider it a difference if it was a morphologic vertebral fracture versus the clinical fracture that she actually sustained as far as treatment?
So the question is, if it was a morphologically proven fracture versus a clinical fracture, would it make a difference? If it was a grade 1 fracture, asymptomatic versus a grade 2 or grade 3, meaning moderate or severe, so if the patient has a moderate or severe fracture or a clinical fracture, in my mind, they're the same.
Yes,
if it was a grade 1 fracture, then it has, we know that the potential future fracture risk is less. That was proven in the Moore trial, looking at grade 1, grade 2, and grade 3 fractures, and the predictability for future fracture risk.
Do you have a maximum number of years? If this were 5 years, would you then give her a holiday if she's stable?
No, if the patient was at high risk for future fracture, I would not stop at 5 years.
You have a max 10?
Probably 10 years.
Mm-hmm. Yes, sir.
I assume that the reason that you're considering the drug holiday is outside the fact that, say, she didn't have a vertebral fracture. You're doing strictly on the DEXA scan treatment for osteoporosis is because of the risk of a severe potential adverse effects, femoral fracture.
The question is, are we reluctant to continue because of the risk of severe adverse effects? I don't really think that risk is really quite substantial. She's tolerating the medication quite well. Next session tomorrow, we're going to talk a lot about these possible long-term complications, like the atypical femoral shaft fracture and ONJ. If you don't mind, we'll talk about it tomorrow. We have a whole session on this. Okay, let's move on. So we're going back now to the 8 weeks, and she's phoned. The back pain has essentially subsided, but she's not taking the bisphosphonate. She has not yet filled her prescription. She says she's feeling much better, does not really feel it is worth taking that medication at that stage. So the lady had a fragility vertebral compression fracture. When she first came, she was in a lot of pain. Now the pain is much better because of the medication and physical therapy and what have you. She was prescribed alendronate, didn't bother to fill it, and you phone her 8 weeks later and she says, "Doc, thank you very much. Pain is so much better. I don't really think I need to take that medication anymore." So at this stage, would you invite her to come back to the clinic to discuss these issues? Would you make a note in her medical records and of her decision that it is medical advice that she stop taking the medication? Do you need to take any action whatsoever, or should she be told that she is welcome to contact the clinic whenever she considers taking the medication for osteoporosis? Or E is a combination of B, C, and D? Cast your votes, please. I'm sure most of you have come across this scenario. So we've got a slight majority of people saying that she should be invited to come back to the clinic, and this is what we actually do. Sandy, would you do it differently?
No, I think it's important to sit down with the patient and explain that osteoporosis, unless you have sustained a fracture, is silent. You will not feel osteoporosis develop. And that I would go through her FRAX score with her, because she doesn't understand T-scores, okay? And I would go through her FRAX, which will be very high, and explain this to her, that this is your risk, and if you do, and you're lucky so far, and that your risk, your 10-year risk, is very, very high, and you exceed the thresholds for intervention. And because you've sustained a fracture, this begets fractures, meaning if she had a fracture, then this would suggest that her skeleton is at high risk for future fracture based on that alone. And so you use whatever tools you have in regard to explanation of osteoporosis and her future fracture risk. I provide the patient with their FRAX scores, I print it out for them, I explain it to them, I show them the vertebral fracture models and all that. I do whatever I can to explain to the patient and send them home with information in regard to osteoporosis. And it's their final decision to make. No one's force-feeding them anything, but I think many times we think as nurses and physicians, PAs, that we're doing a fantastic job in education. We think that. I think that. But in some cases, our message does not come across. For whatever reason, the patient could be thinking of something else. The patient is agitated about some other family member who has a major problem. Whatever the case may be, I feel that reinforcement, re-education, continued education is really important when I see patients in consultation.
So again, making sure the patient really understands what is going on and is fully involved in developing the treatment strategy. And she may prefer to go on another anti-resorptive. She may find that the routine of taking that medication is not convenient to her. She may have heard something, or her neighbor may have told her about ONJ and atypical fracture or what have you, or she may have been surfing the net. Or she just finds it inconvenient, and in that case, maybe denosumab would be more appropriate. Would anybody consider giving her, at this stage, zoledronic acid? Hands up who would. Hands up who would not, at this stage, give her zoledronic acid. I personally would be reluctant to give her zoledronic acid at this stage because I'm really very concerned about the acute phase reaction, which, if you remember what Dr. Boehm said earlier today, to the patient who is naive towards bisphosphonate, if you prescribe the zoledronic acid infusion, 18%, that's almost 1 in 5, is likely to develop the acute phase reaction. And the chances are very high after that she won't come near your office, she won't pick up the phone, she won't answer your calls because she say, I'm sick and tired of your medication, that was a terrible medication. Dr. Boehm, what have you done to me? You've ruined. It did happen to me. The very first time I used zoledronic acid was the week just before Christmas when zoledronic acid came. I had a patient very, very similar to her. No, I'm not going to take these stupid tablets. I hate these tablets. I'm not going to take them. Have you got anything else? And zoledronic acid was available. So I gave her zoledronic acid, and then I thought I was going away on vacation. Somehow she got hold of my cell phone. And during the Christmas, New Year period, I had calls from her almost every day. And instead of taking the usual 3 to 5 days to be relieved, it took the full 2 weeks, Christmas and New Year. So that's why a patient like this, I don't usually like to prescribe zoledronic acid to patients who have not been on bisphosphonates. So what I would tell her is, look, I've got some very good medication. Instead of taking it once a week, you can take it once a year. However, to reduce the adverse effects, I want you to go on these tablets for 3 months so that your body gets used to it. And then when you give you the zoledronic acid, you won't have any adverse effects. Unfortunately, you've got to tell them why you want to do this, and they only hear adverse effects, and they say, adios, doc, I'll see you sometime later, maybe. But it's worthwhile considering zoledronic acid, but give her 3 months first with the regular oral bisphosphonates. Any questions? Yes, sir.
That's the first time I've ever heard that.
Heard what?
Heard give somebody, alendronate for 3 months and then change them because of the...
Yeah. I mean, it's been shown that if the person is naive to bisphosphonate, 18% develop the acute phase reaction. If the patient has been on a bisphosphonate before, instead of being 18%, it's down to 9%. And if on top of this you give the patient non-steroidal anti-inflammatories or acetaminophen, it's reduced to 4.5%. I personally don't like to use the non-steroidals because I'm concerned about renal problems. So if there is any doubt, I prefer to go with acetaminophen. And as Dr. Bim was saying earlier this morning, you give it for 2 or 3 days to make sure that the risk of acute phase reaction is very much reduced. But yeah, and if you let the patient know from the beginning that, look, it's only for 3 months, and then we'll convert you to the other, and you explain why you're doing it, most patients in my clinic accept it. Okay, let's move on. So she comes to the clinic and she appears to be convinced of the need to take the medication for her osteoporosis. She is agreeable to taking it. Okay. At this stage, the fasting CTX level should be assayed and repeated 6 to 8 weeks later. The 24-hour urinary NTX should be assayed and repeated 6 weeks later. Or the serum bony isoenzyme of alkaline phosphatase should be assayed and repeated 6 weeks later. And you've got various combinations or none of the above. Cast your votes, please. So just to put things in perspective, patient has sustained an osteoporotic clinical vertebral fracture, fragility fracture. We started her on alendronate. She didn't fill her prescription. We've invited her to come back. She comes back. We convince her, and she says, yeah, okay, I'm going to take it. Can I have the prescription, please? Do you let her go, or do you check on the bone markers? Okay, we seem to have some consensus. We need to check the bone markers, and as you've heard about our discussion a few minutes ago, this is a time where I personally would definitely go for the bone markers because I'm not so sure is she really going to continue with that medication or is she going to stop it. I'm not even sure she will fill the prescription. So I would contact the insurer and say I'd like to do the markers of bone turnover. And I'd like to do it now and 3 months later, and then we proceed that way. Because, again, I'm not sure, even if she assures me that she's going to take the medication, I'm not sure she will be taking it. So this would be one way of confirming it. And then if you do it and you find, let's say, the CTX is 800 at baseline, she comes back 2-3 months, 2-3 months later, and is still hovering around the same level, she's either not taking the medication or she's not taking the medication the way it should be taken. And then I would confront her and say, look, you've been on this medication for 3 months. It's not working. And we need to change you to some other medication. So now I have good material to convince her that for whatever reason she's not taking it. Maybe it's not working, maybe because she's not taking it. Sandy, would you agree with me on this? Or?
I always agree with you. I think that we have to appreciate that there's variability and suppression of biochemical markers of bone remodeling with the different agents. So as we talked about, denosumab will suppress bone turnover within a week. So it's a very rapid onset drug. And that's how we see the effectiveness of it in hypercalcemia. It's dramatic. Same thing with zoledronic acid. That's a very rapid onset. Within weeks, it works to suppress dramatically biochemical markers of bone remodeling. With the oral agents, it takes a while. And if you want to exclude the variability of testing from the response of the markers, I wait a little bit longer than 6 weeks because of that. I wait up to about 6 months to be sure I'm at the NITR, or it's going to be as low as it's going to go, marker time.
And don't forget, we're looking at changes exceeding 30 to 40%, so
right.
We need big changes.
So,
okay,
yeah.
Let's move on. So the fasting CTX before taking the bisphosphonate is 820. 12 weeks later, it's 400. So from this data, it's been reduced by more than 50%. It can be concluded that she is taking the bisphosphonate as directed. The bisphosphonate has significantly reduced the rate of bone resorption. She should be shown the results, complemented on taking the bisphosphonate and encouraged to continue taking it. She should be told on the phone that the results of the tests are good and she should continue taking the medication. And E is A, B, and C. And we seem to have majority would be that she has taken it as directed, it is working. And again, it is important to invite her back, and this I would invite her back and say, you've done a great job, I'm really proud of you, please continue as you're doing, there's the evidence that it is working. And then this way you can be sure that she's bought into the program, she's got a vested interest, she is motivated to continue because she sees for herself, oh my goodness, it's come down from 800 to 400, fantastic, I must be doing the right thing, this medication might be working, and she would be motivated to continue. I spend a lot of time trying to motivate my patients because if they're not motivated, they're not going to take their medication. And indices we have to monitor the patients on it, not really all that good. Even the bone markers, they're quite fluffy. So very important to get the patient to buy into the management program. Okay. Another case scenario, the fasting CTX before taking the bisphosphonate is 820. 12 weeks later, it is 810, so it hardly changed. The conclusion is that she's not taking the oral bisphosphonate, she's not taking it as directed. A parental bisphosphonate or denosumab should be recommended. Parental bisphosphonates, denosumab or teriparatide is recommended. Raloxifene, parental bisphosphonate, denosumab or teriparatide should be recommended. And is it A and B or C or D? So we all agree that if these are the results, all agree, it's only one, I thought it was 11. 3. Come on, folks. 4. 5. One more? Okay, so we seem to have some agreement that she is not taking the bisphosphonate as directed, and then either prescribe an oral or some various other treatment for osteoporosis. She definitely needs treatment for osteoporosis because if you remember, she developed a fragility, a clinical vertebral fracture. So regardless of the T-score, she's at very high risk. And which medication you use is very debatable. We've covered all the medication earlier this morning. So the bottom line is you need to prescribe her something, but clearly the oral bisphosphonate is either not taken as directed or it is not working. We need to change strategy. Leaving her on the oral bisphosphonate is meaningless because there hasn't been any significant change in the bone markers. Are we okay? Any questions? Okay, let's move on. Now we've got another scenario. And the scenario here is that she's still prescribed alendronate. 8 weeks later, we have the phone call. The patient says the back pain has subsided. And she says that she is taking the medication with effervescent vitamin C tablets that her son-in-law recommended. Her son-in-law has just been accepted to School of Pharmacy. And he recommended that she takes the vitamin C and that she takes it in the morning at least half an hour before breakfast. But take your alendronate with effervescent vitamin C. She's taking it. She thinks her son-in-law is terrific. She's not experiencing any adverse effect and is happy to continue taking the medication. So at this stage, would you remind her that she should take the oral bisphosphonate on its own, no other medication, no food, no beverage, except for water? Would you recommend her of the importance of taking the medication exactly as directed and not with effervescent vitamin C? And would you make another phone call in about 4 weeks' time to ensure she's taking the medication as directed? D is A and B, E is all of the above. And we've got consensus, all of the above should be done. Are we okay with this, or do you want me to go over it? Are we okay? Okay, let's move on. Another scenario now, she stopped taking the medication because it induced upper GI adverse effect, and this is when the phone call is made. She said, no, I stopped taking it. It's causing me too much GI problems. So at this stage, would you invite her to come back to the clinic to discuss other treatment options? Would you prescribe a PPI before she takes the bisphosphonate? Would you tell her that she should tolerate these symptoms and continue taking the medication and stop whining about? Or would you make another phone call in 4 weeks' time to ensure she's no longer experiencing the upper adverse effects? And I think we've got consensus here that the best option is really to invite her to come back and discuss the issue. Again, I keep re-emphasizing this point is very important to get the patient to buy into the treatment management and really to take ownership of it. Otherwise, she's not just going to comply. So just phoning her at this stage or telling her that she should tolerate these symptoms doesn't really make much sense. Sandy, anything you want to say?
I think I'd ask her to bring her son-in-law in.
Right.
To discuss things, because you never know what he's going to think after you.
Yeah,
there may be a
actually,
debate.
this is very, very true.
So I'd have the son-in-law come in and you bring out the data, the pharmacologic data, so he buys in also and discuss it.
That's very, very good, yeah. I did it once with, instead of son-in-law, it was daughter-in-law. And the patient was a man. And she was just been accepted to School of Nursing. But that was the only way. I didn't do it initially. And then when phoned her later on, she still wouldn't take it. So this one I said, why don't you bring your daughter-in-law with you and we'll talk about it. But again, very important to make sure the patient buys into the program. Otherwise, they're not going to comply. Okay, another case scenario. So she's phoned, and now she stopped taking the medication because it caused lower abdominal pain. And I hope you remember we did address this earlier this morning. And often she has diarrhea and flatulence. Typically, they occur 2 to 3 hours after taking the bisphosphonate. At this stage, would you make inquiries should be made as to whether she's having breakfast about 30 minutes after taking the bisphosphonate? She should be recommended to increase the fiber content of the breakfast she's taking about 30 minutes after taking the bisphosphonate. She should be told that she should tolerate these symptoms and continue taking the medication and stop being a baby. Or should you make another phone call? Should you schedule another phone call about 4 weeks later to ensure she's no longer experiencing the adverse effects? And E is a combination of A, B, and C. And we've already talked about this. We said the main reason for this is the unabsorbed part of the medication gets in the intestines, gets in contact with the intestinal mucosa, irritates it, induces peristalsis, which the patient interprets as colicky, or if it's quite a lot, it may actually lead to a bout of diarrhea. Happens quite frequently. So the best thing is to recommend that she increase her dietary intake, her fiber intake 30 minutes after taking the medication. Another case scenario, she stopped taking the medication because it's causing her to have severe aches and pains in her joints and bones. And she's glad that you phoned because she's not going to take this medication anymore. It's a terrible one. She should be reassured that these pains will eventually subside. She should be encouraged to continue taking the medication. Again, grow up and be sensible, take that medication. She should be prescribed acetaminophen, 500 milligrams 4 times a day. D is A and B, and E is all of the above. So we've got a majority saying that she should be reassured that they will subside, continue to take the medication, and prescribe acetaminophen. That seems to be the consensus. Andy, what do you think?
I think that it's really important to distinguish whether there is any other pain that could be associated with the patient's symptoms also. All right? Because at 70 years of age, people can have a variety of other etiologies. So I'd probably want to sit down with her and examine her and determine if this is, which is very common, arthritis, pain, other types of disorders, and sit down and discuss it if it could be the medical therapies. The other one option is that at the time of discussion, after examination, you then believe, well, maybe this is the medication. So you have a choice. We have a choice. So I negotiate with all my patients. Negotiation is part of our job. And I offer them options. We can take acetaminophen. If there's possible arthritis, I use an anti-inflammatory. If they can tolerate it, with it, use both. The other option is, do you want to stop it for X number of weeks, and then we'll scientifically restart it if there's no arthritis or anything else going on, and see, using the scientific method, see if it reintroduces the same symptoms. So we go through this negotiation process to determine what's the best, or what's the most reasonable choices that we have in our negotiation. The patients appreciate this when you incorporate their needs and their desires, their solutions as well. They have confidence in you. If you just reassure them that this will eventually subside, and it doesn't subside, are they going to be reassured of your medical acumen and your understanding of the disease process? Not necessarily. But if you go through the negotiation and truly appreciate their concerns, you're assured that this is the potential etiology, these are the options that we can provide. Which way do you want to go, Mrs. Jones? And then let's proceed and see what we come up with.
That's Mrs. Brown, actually.
Oh, Mrs. Brown, I'm sorry.
The other thing I found very useful is actually to lay your hands on the patient.
Exactly.
go through the motions, do a brief physical exam of the locomotor system, range of motion, where is the pain beginning, and really be systematic. And you'll be amazed how much the patient's confidence in you increases if you lay your hands, make sure you use your privileges as an MD to examine the patient. You may find that she's got a gouty arthropathy, that she may have the arthritis, the rheumatoid has flared up or whatever. So examining the patient is terribly, terribly important to reassure the patient that you really know what you're doing. This guy examined me. He spent 3 minutes. He looked at every single of my joints. He knows what he's doing.
I just want to reemphasize that point because I hear this from innumerable numbers of patients. Nobody examines me anymore. No one touches me. No one holds my hand. No one does this. This is commonplace.
And this builds up a lot of the confidence. And again, the patient says, oh, yeah, I trust Dr. Baim. He's really very good. He knows what he's doing. Right, Laura? I don't know.
Yeah, of course.
Okay, are we okay for this question? Okay, let's move on to the next one. So another case scenario. Now she stopped taking the medication because she experienced palpitations. So we're about 8 weeks, 12 weeks now. She saw a cardiologist who diagnosed atrial fibrillation and recommended that the oral bisphosphonate should be stopped. He put her on a Holter monitor, picked up the atrial fibrillation that is paroxysmal, and said, you really need to stop that medication. She should be invited to return to the clinic to discuss other therapeutic options. She should be reassured that atrial fibrillation is not an adverse effect of bisphosphonates, and you could show her the paper from the FDA. She should be encouraged to resume taking the oral bisphosphonate. She should be prescribed zoledronic acid infusion once a year for the next 3 years. And E is B and option C. One more? And I think we've got consensus here. Again, the thing is, bring her back to the clinic and talk to her. If the cardiologist says, I don't want you to take this medication because of atrial fibrillation, even if we are 100% sure that atrial fibrillation not related to the oral bisphosphonate, I personally think it'd be prudent not to continue with it and say, okay, yeah, we're going to discontinue it, even though very internally I would say, cardiologist doesn't know what he's talking about. He hasn't read the latest. But at least as far as the patient are concerned, I say, yeah, he may be right. I'm not so sure, but I agree with him. Let's not go on the bisphosphonate. But by the same token, I would not give her zoledronic acid just in case. And there were a few reported cases of atrial fibrillation. That's why the FDA looked at all this procedure, at the results. So I would be inclined to get her to the office and discuss with her other therapeutic options. Yes, ma'am.
Do you ever take them off the medication for 3 to 4 months and then restart them to see if they drop their glucose?
The question is, would you take her off the medication and then restart her a few months later? I would be very nervous to do it just in case she develops another bout of paroxysmal atrial fibrillation, which is probably totally unrelated to the bisphosphonate, but in her mind, the two are connected. And we know that atrial fibrillation is very common among older people. She's 70 years old, so she's a prime candidate to have these. And if you start the medication and she has another bout of atrial fibrillation, automatically she's going to blame you and say, this Hamdi guy, he doesn't really know what he's talking about. This is cardiology. My cardiologist knows everything, and you've lost that patient. And not that it matters, but at the end she may fracture. So I'd be reluctant I'd be inclined to stop the bisphosphonate, maybe give her denosumab, or even go with teriparatide. Cindy?
I think I would chat with the cardiologist directly. I would actually send him the full analysis of all the papers. There's numerous papers on this, reviewing the potential of atrial fibrillation. And I would ask them, can you look back in your chart, or I'd ask the patient where their previous EKGs were, or rhythm strips prior to institution of medical therapy, meaning prior to the bisphosphonate, to see if the patient actually had atrial fib or another arrhythmia prior to institution of this medical therapy. And then work with the cardiologist. You don't want to battle anyone. You don't want to really negate any potential in maybe this rare case. But I'd talk with the cardiologist first, not take just the patient's viewpoint. But maybe the cardiologist said something different, and you're not sure. So I would go back to the source, discuss things with the cardiologist, provide them with the papers, and ask them, can you go back and see if she's ever had this before? Is that what you really said? Do you really believe this? Let me show you some data that's fact and not fiction. And then negotiate with the cardiologist. And if he says, I believe this is drug-induced, then there's no way.
Yeah.
You're not gonna prescribe it. If he says to me, okay, I'm not really sure, the patient really didn't take what I said exactly, and manipulated it to say, I don't want to take anything, even if there's a rare chance, that's a different story. So you really have to discuss it with the cardiologist. That's my gut feeling on that one.
Yes, sir.
Besides age, is there a pathophysiological relationship between atherogenesis and osteoporosis?
Between
biochemical relationship between the process of atherogenesis or atherosclerosis and osteoporosis?
Well, what's interesting that these arrhythmias, correct if I'm wrong, occurred by an average of about 30 days after the intake of, it was after zoledronic acid, wasn't it?
Yeah, it's not, even with the, it has no relationship time sequence, but that's not your question, I think. No. So, is there a relationship to...
biochemical linkage, it's been in the literature, that the two diseases are basically the same based on certain biomarkers.
So,
to repeat the question, please.
Are there biochemical markers of inflammation or something that we see in osteoporosis and also in coronary artery disease, arteriosclerotic disease, whatever?
Go ahead.
I don't know. I don't know if it's firmly placed. I don't know if it's an absolute association. I don't know that they have actually proven that. Okay? I don't believe so.
I think
this particular patient, if she's going to have an SPT or AFib, he's going to put her on an anticoagulant, and you sure as hell don't want her on a Alendronate, and she's on an anticoagulant, and she bleeds out, and her son-in-law is an attorney.
I think the consensus is we're going to stop the alendronate and give her something else. If you go back to the markers of inflammation, there are so many of these markers around, and the population we're dealing with, 70 years old, they've got so many other parameters that may affect these parameters that I'm not so sure. It's not as clear-cut as the various laboratory tests because all these older people have got so many pathologies going on that these markers could be elevated for whatever reason. So to say that the two are related, I feel uncomfortable about it. But I think the wisest would be to stop the medication, bring her back to the clinic, explore alternatives, and at the same time, as Sandy was saying a minute ago, to make sure that cardiologist knows what the situation is. Maybe too late for this patient, but at least for future patients, he may not say, because I haven't yet seen a cardiologist change his mind. I don't know about you, Sandy, but once they make up their minds, it's, and surgeons are...
Are there any cardiologists in the audience?
No cardiologists, okay.
Well, hopefully somebody with AFib and osteoporosis, hopefully somebody did a TSH.
You would think so. Because I just had a patient actually exactly like this with AFib, and I mentioned that earlier, the patient that came in with iatrogenic-induced hyperthyroidism. And I explained to the patient that not only is this exacerbating your osteoporosis that didn't respond to previous therapies, but it may be associated with your arrhythmia. And I sent it to the cardiologist, too.
Picked up her AFib due to Graves' disease by
Right. Right.
Okay, let's move on. Now, another scenario, she stopped taking the oral bisphosphonate because her son-in-law told her that these medications actually increase the risk of fractures. As you can see, son-in-law, future pharmacy student, is very, very well learned, but he scared the hell out of her because he told her that, no, your doctors are wrong, these medications can actually increase the fracture risk. So again, the same options. She should be invited to come to the clinic, should be reassured that these are very rare, should be switched to another anti-resorptive medication, B and C or A, B and C. Cast your votes, please. And again, I think we seem to have consensus. The best thing to do is invite her to come back to the clinic to discuss these various issues. As we mentioned earlier, maybe invite the son-in-law to come and bring his literature with him. Make sure you clear your appointment book for at least, I would say, 30 minutes, 45 minutes, and good luck to you. But and then maybe switch her to another medication. Okay. Another case scenario. She stopped taking the oral bisphosphonate because she experienced pain in the jaws, and again, that clever son-in-law told her that this medication may cause her jaws to rot, what is known as osteonecrosis of the jaw. Do you invite her back? Do you reassure her? Do you switch another resorption? And it's almost an exact replica of the previous one. You invite her to come back and look at the evidence, and I'm not so sure you can convince her of the evidence, but at least you're getting closer to getting her to buy in the management program, and she's very involved in it. So it pays to invite her back to come to the clinic. Okay, another case scenario. She has not taken the oral bisphosphonate at all. She hasn't even filled the first prescription. She says she's feeling much better, doesn't need... Actually, we've already covered this. Okay. 1 year after starting the oral bisphosphonate, she's concerned because about 2 weeks ago, she developed an itchy erythematous vesicopapular rash on her back. Would you prescribe topical cortisone? Would you stop the bisphosphonate because she may be allergic to it? Would you reassure her that these are very benign? Would you refer her to a dermatologist? Or would you ask her son-in-law to have... No. So we seem to have a slight majority about referring her to a dermatologist. Sandy, do you want to comment on this? Or?
Well, I would do the same. I would send her to a dermatologist to get an appropriate evaluation. Skin rashes are frequent.
Any comments?
I mean,
Okay.
This could be anything. Could be...
And 13, this is a majority to refer to a dermatologist.
Could be zoster, could be anything.
Okay, could be. Yeah. Okay, she's concerned about ill-defined pain in the lower end of the femur and upper end of the tibia on both sides and also on the shoulders. She should be reassured about the benign nature of this condition. The pain she's experiencing is similar to that of growing pains in adolescents. Medication should be stopped immediately, and she should be investigated for insufficiency, fissure fractures, and teriparatide should be prescribed, or A and B. We'll talk much more about atypical femoral shaft fractures tomorrow. The pain is ill-defined, lower end of the femur, upper end of the tibia on both sides, and also on the shoulders. As we'll see tomorrow, this is not a typical presentation of atypical femoral shaft fractures or insufficiency fractures. But 16 here would stop the medication. Do you want to comment? Or?
Well, I think I would bring her in and examine her, because this is not typical of atypical femur fractures, and determine if this is just arthritis, because it's in multiple joint regions.
And as we said earlier, examining the patient is very, very important, especially in her case, because it's both shoulders and both knees. It would be worthwhile doing a clinical evaluation. Okay. Her son-in-law is back. Now she has ocular pain associated with bilateral redness in the eyes and diminished vision in both eyes. She should be urgently referred to an eye specialist. She should be told that it's a benign condition. She should be prescribed eye-soothing lotions or BNC. And I'm glad most of you agree that she should be sent urgently to an eye specialist. It could be uveitis because of the redness and the ocular pain, and it's bilateral and diminished vision. You really don't want to take any chances at all. This is an urgent referral. Do you agree, Sandy?
Absolutely.
It's something that many, many people seem to be unaware of. These ocular complications of bisphosphonates are very rare, but you don't really want to miss it. And the hallmark is the pain, tenderness, diminished vision, and redness. Okay. Mrs. B is about to have 4 dental implants. She wants to know whether she should stop the bisphosphonate. She has been adhering well with the medication, and now she's been 4 years on it. So would you stop the bisphosphonate immediately? Would you ask the dentist to postpone the implants for 6 weeks after stopping the bisphosphonate? Would you have a CTX assay, bone marker, or would you prescribe teriparatide, or would you do A and D? So one person stopped, 2 people stopped, 3 people, 4 people, everybody stops bisphosphonates. Okay? So she's been on 4 years now on alendronate, and you're going to stop the bisphosphonates.
I think she's on 1
Do
year.
you really think 6 weeks after stopping the bisphosphonates it will have any effect? No. Very, very unlikely.
The dentist is one question to stop.
What's that?
Usually it's the dentist or...
This is 1 year.
The dentist here.
I think this is 1 year. This is after 1 year.
Oh, okay. Good.
So if it was 1 year versus 6 years, does that make a difference?
So she's been only 1 year on alendronate, just 1 year.
Does that change your opinion? Does that make a difference in the potential risk? So does 1 year of bisphosphonate, is that associated with ONJ? Is that ever seen? The answer is no. It's not usually 1 year. It's as you proceed into 3 or plus years that there is an increasing incidence of ONJ. So it is unlikely that there would be an adverse effect. But even after 1 year of bisphosphonate, if you stop it, is the circulating level in the serum going to be any different within a couple weeks? No. It really won't. Would a serum CTX make any difference? No, because you know it's going to be suppressed anyhow. So this is a trick question Ron came up with. So you have to ask Ron.
Let's take one step at a time, and let's assume it is just 1 year of treatment and she needs the implants. Do we stop who would stop the bisphosphonate? 1 year alendronate therapy, she's about to have implants. Do we stop the bisphosphonate and say the implants could go ahead 6 weeks later? Hands up who would do that. Hands up who would not do that. Okay, so you're still with me. Because as you were saying, 1 year is really not enough time. 6 weeks, I don't really think very much is going to change. But for your own peace of mind and the dentist and the patient, it might be better to pick 6 weeks and not do it. If she's been 4 years on alendronate and she's been complying and now she needs implants, most dentists would refuse actually to do the implants unless they look at the CTX. I don't know if the same thing with you.
Right, and I think you'd look at the American Academy of Oral, or College of Oral Maxillofacial Surgeons and their recommendations, and they say that if the patient absolutely has to have dental surgery, invasive surgery, you need to do it. Okay, there's no way around it. Stopping it will not make a difference. Meaning they understand this too, meaning their own society. So this is, and then the ASBMR, the American Society of Bone Mineral Research, that is also in their task force that also has oral surgeons involved with this, say the same thing. They're very similar. You really can't change anything acutely by stopping bisphosphonates. It's only making the dentist, who may not fully appreciate his own society's guidelines, and the patient feel better. But I think the key issue is before you start therapy to explain this also to the patient. The potential unusual rare side effects with a bisphosphonate or denosumab in regard to what would happen. So if you're going to have surgery, possibly in the future, implants, let's do it now before you start. And that's what I do.
Yes, ma'am.
Is the latest incidence of that, osteonecrosis? I'm not really involved.
Can you repeat the question louder, please? Actually, there is a microphone. Why don't you use it?
Incidence of osteonecrosis of the jaw.
Okay, so the question is, what is the incidence of osteonecrosis of the jaw? It's so rare that we don't really know. Various figures have been branded, like 1 in 20,000, 1 in 10,000, and so much higher, but it is so rare. The other thing to remember is that the majority of cases where ONJ was described were patients who had neoplasia, often with secondaries, usually hematological, so either multiple myeloma or one of the hematological neoplasia, who were being treated with chemotherapy, and often they had other predisposing factors, particularly cigarette smoking, poor dental hygiene. And as you know, there have been quite a number of lawsuits against the manufacturer, especially of zoledronic acid. Patients develop osteonecrosis of the jaw, but most of them, there were so many other factors that predisposed to it that it's very difficult to directly blame this. However, as we will see tomorrow, there is a scientific explanation, there is a rational explanation as to why patients on bisphosphonates are more likely to develop atypical femoral shaft fracture and osteonecrosis of the jaw. We'll talk about this tomorrow, but the main issue is that it is an extraordinarily rare condition in patients who are on bisphosphonates because of osteoporosis. Any other questions? Yes, ma'am.
So just to clarify, you're saying that the ASBMR and the oral surgeons just say if you have to do it, don't stop it, just keep them on it, don't worry about it.
What you can do, however, I mean, that's a very good point. The point was if the surgeon says you definitely need to have the surgery done now, it is an urgent situation, you may want to go ahead with it. Your other weapon that we haven't talked much about is to give teriparatide. And we know that teriparatide can actually help healing the osteonecrosis, but we'll talk about this tomorrow, second session. Yes, sir.
You know, about 10 or 15 years ago, the drug companies were just saying, oh, this is not a big deal, it's 1 in 150,000. You know, I think Kaiser or somebody came out and said, ooh, there's 1 in 2,000 in our population. I actually had a patient who had been on alendronate for 7 years. You know, I didn't prescribe it, but I probably would have at that time, who got OMJ, had no risk factors, lost her teeth, very difficult, severe problem. You know, when you take a woman at 60 years old and she loses her teeth and gum disease, bone disease. So it is a real thing. It's serious. It's rare, thank goodness. But you can't poo-poo, because if it happens to one of your patients, you know, it makes you a believer.
I don't want to take too much thunder out of tomorrow's session. It will be devoted, half of it is going to be on atypical fractures, other half on osteonecrosis of the jaw. But I just want to introduce another concept. Many patients with osteonecrosis of the jaw or even atypical femoral shaft fractures in these lists of patients were never on bisphosphonates. But we'll talk about this tomorrow. Any other questions? Okay, let's move on. And now we've got another case scenario. Now she's been 6 years on alendronate therapy. She's adhered well to the therapy. She has evidence of gradual sustained increase in BMD and decrease in T-score. Now her lowest T-score is minus 1.9. At this stage, she's been 6 years on therapy. Would you discontinue the bisphosphonate? Would you continue it? Would you repeat the scan in 2 years' time, A, B, and C, and she's in for implants, can she go straight for the implants? Sandy, would you mind answering this for a second? I'll put return a call. Oops, sorry.
All right, so I think that most individuals...
Hey, Gerard, how are you? Sorry, I couldn't take your call. I was in the middle of a conference.
Can you let him know?
Are you on your way home?
So that was an emergency call, so that's why I'm up here. So basically, the question is this patient ready for a holiday, a drug holiday, as we talked about? And after 7 years of therapy, the patient has responded. There's no using your primary endpoints of fracture. The patient has not fractured again. Surrogate markers like BMD and biochemical markers that you potentially performed show major and excellent response. And I would discontinue therapy in this patient as part of a drug holiday. Drug holiday, as we talked about, is not permanent. It means that we're going to follow that patient off of therapy as well. Should we consider this patient for implants? Well, 7 years of therapy. What happens with 7 years of therapy and serum levels of bisphosphonate? Data has been accumulated in regard to the terminal half-life of, say, alendronate. And it is suggested that after 10 years of therapy with alendronate, 25% of the oral dose would still be circulating after 10 years of oral therapy if you stop therapy, because of the embedded bisphosphonate in bone and the remodeling of bone bring that bisphosphonate out into the circulation again. You would have potentially years of bisphosphonates still recirculating. Remember that bisphosphonate is embedded in bone as it attaches to bone. And as part of the remodeling process, the osteoblasts fill it in. So that bisphosphonate's within the bone. And after 10 years of use, with a continued remodeling of bone, even though it's at a lower rate of remodeling, then those resorption sites then find that old bisphosphonate and it comes out into the circulation to be reabsorbed onto new bone remodeling sites. So from the standpoint of can she proceed with implants, it's still going to be circulating after 7 years of therapy. And as we talked about, most of the societies believe, including the oral surgery societies, that if it absolutely has to be done, it's a must, that then you should proceed. Meaning if the patient has an abscess for some reason, they have a decayed tooth, it has to be pulled, something, it has to be taken care of, then you go ahead and perform that surgical intervention. One of the major issues that we'll be talking about tomorrow is to be sure that the patient has a complete oral examination before you start surgery, that the patient has regular dental appointments for the best potential oral hygiene throughout your therapy, and that any periodontitis, anything that is going on, be treated appropriately by the patient's dentist or oral surgeon throughout their treatment phase. But to say that the last point here, that she can proceed, that would be up to you, the patient, and the oral surgeon to discuss this and be very frank about the risks. You're not 100% sure, but if you absolutely have it, there's still that risk, even though low. Okay? Yes, please.
Can I just ask about one step further on this, because it's a problem I've been running into?
Sure.
We've done the drug holiday, so now say 2 years out, we do a DEXA scan, she's stable, or maybe has some minor decrease, and then we plan on staying with the holidays, say we go 2 years out again, now the DEXA scan, we're saying we're having continued decrease, we need to talk about reinitiating therapy. Do you reinitiate a bisphosphonate, or say she's only been on 4 or 5 years previously, or would you automatically go to something like Prolia instead?
Well, I think that brings up an important point. Firstly, we talked about the precision error and least significant change. So I'm assuming that you're saying that the patient's change was that they met or exceeded the least significant change at that bone density testing center. Then that's saying, and then you could potentially do your biochemical markers at the same time, say, oh my goodness, here's your baseline when you discontinued therapy, and they're also high as well. And with those two surrogate markers, you're showing that the patient's losing effect of drug therapy, of suppression, okay? The usual offset, or the offset that is stated with long-term bisphosphonate therapy, is about 5 years. So that after 5 years, unless the patient's been on 10 years of therapy, but in today's day, we don't continue therapy forever unless they're at high risk, as we talked about, then the offset's stated to be around 5 years of therapy. And so if the patient is losing bone mass, you reassess their fracture risk at that time. Are there new risks? Is the patient on new medications? What's happened to the patient? And then make that judgment based on all facts at that time, whether the patient should be on teriparatide, okay, or denosumab, or replaced on the same bisphosphonate that was effective in increasing bone density by a significant degree. I cannot tell you which drug to use. That's not my job up here. My job is to provide you with options to think about at that time of decision making, because every patient has to be individualized. I'm not trying to run away from that question.
That's where that tough line.
Yes, I totally agree with you. I totally agree with you. But if the patient is on glucocorticoids, then, you know, if the patient has had multiple fractures, if the patient has major systemic disease and will not absorb that oral bisphosphonate, it will totally change your opinion on which medical therapy to institute. And say you lost contact with that patient for a couple of years, they never came back. Then they come back and they have all these other clinical risk factors that were not apparent at the time of initial presentation. Would you really reinstitute that therapy or a different therapy immediately, or would you reassess for other potential risks that you had done 7 years before? And the answer, from my standpoint, I would reassess that patient.
Right.
Absolutely.
I guess my point is bringing them back in, reassessing.
Absolutely. That's what I would do.
I would absolutely do that. That's fine when I reassess. They're still believe, yes, that would be a reasonable thing to continue going back on bisphosphonate that she was successful with.
We are dealing with expert opinion. There is no published data. The longest data is the FIT trial with the flex extension, 5 years on, and then those patients on were continued for another 5 years or they were taken off. Okay? And so out of thousands of patients, we're left with just hundreds at the end of 10 years. That's the only really long-term data. Other than the zoledronic acid 3 years and 6 years, that's the only fracture data that we have. Okay? So we're running in a data-free zone, as we call it. And so, we're dealing with clinical factors. It's better to reassess completely and sit down with the patient, discuss things, and then make that decision with the patient. Those are really excellent questions. Any other questions regarding this topic? Okay. Relax.
Thanks.
Let's take it easy.
Thank you. Okay, so let's move to the next scenario. And the patient has adhered well to her therapy. There is a gradual sustained increase in BMD, decreased T-score. Now lowest T-score is minus 2.6. At this stage, should you discontinue the anti-resorptive? Should you continue the anti-resorptive? And in either case, would you repeat the DEXA scan in 2 years' time? Okay. So there seems to be a preponderance of continuing the anti-resorptive, and she's responding well. There has been a gradual increase. She's happy to continue taking it. She's adhering well, so she should continue taking it, and we'll repeat the scan in 2 years' time. Any disagreement, Sandy? Anything you want to add? Okay. Now, the other scenario, she's adhered well to the therapy, but there has been a decrease in her BMD, and the decrease exceeds the least significant change. Her lowest T-score is now minus 2.8. Would you discontinue the therapy? Would you continue? Would you investigate her for secondary osteoporosis? Or would you combine these two, and that would be answer E. So majority would continue with anti-resorptive and would see the patient 2 years later. Are you really happy with this? There has been a decrease in the BMD. Continuing with something that doesn't seem to be working, is it really a good idea? I mean, not only is she not responding, she's gradually deteriorating in front of our eyes. We've got other medication apart from the anti-resorptives, and even among the anti-resorptives, we've got other medication apart from the bisphosphonate. What are the three commonest causes of non-response to bisphosphonate? Number one is the patient is not taking the medication as directed or is not taking the medication, period. Number two is not enough calcium, not enough vitamin D. She may have hypovitaminosis D. And the third group is secondary osteoporosis. So I'm not really inclined to continue with bisphosphonate and wait for another, just to continue. We really need to find out why is she not responding. Now, she tells us she's adhering well to the therapy, which may be the case, but we need to find out. But even if she's continuing with her therapy, we need to find out why she's not responding. And this could be vitamin D deficiency, it could be secondary osteoporosis, could be a multitude of things. It would make me very nervous to continue with the present anti-resorptive therapy. Sandy, what do you think?
Well, I agree. I think that this would be considered a non-responsiveness to medical therapy. And if the patient has stable or increasing bone mass or bone density, that's good. I'm happy with that. Patient's not fracturing, that's great. But when the patient is losing bone density or bone mass, as we say, then that's concern. And we have to delve into that to determine the etiology. That requires reinvestigation, reanalysis of what's happened. I had a patient like this once, and the patient said, I'm taking my medication, I've done everything you've asked me to do. And I said, Mrs. Brown this time, right? Mrs. Brown, well, we're going to have to do a total analysis to determine if there are supervening etiologies for your bone loss. And this may cost $10,000. This is exactly what I said. And she said, okay, let's go ahead and do this comprehensive assessment. So I said, okay, I'm ordering it. So I order all the tests. She calls me back the next morning. I cannot go through all this expense. I really didn't take my medication. So that was a trigger. I sometimes use that as a trigger to be sure that my patients understand that we're not fooling around here. We're going to really reassess for everything, to reassess for other potential etiologies. And what I have found in the interim is primary hyperparathyroidism. I found myelomas. I found other potential etiologies, including forgetting to take vitamin D, calcium, having a mineralization disorder, really having low-grade osteomalacia or something like that people have, they develop. So it's really important to reassess at that point.
Okay, so another scenario, she's adhered well to the therapy. After the initial improvement at year 3, there has been a gradual decrease in BMD and T-score. There has been no change in evidence of a Anyhow, there has been a decrease, and the T-score is now minus 3.1. So after the initial improvement, there has been a decrease in BMD, and the T-score is now 3.1. This sentence should have been deleted. My apologies. So after the initial improvement, there is a deterioration. Now she's got minus 3.1. At this stage, would you discontinue? Would you continue? Would you investigate for secondary osteoporosis? And this is very much the reverse of the scenario we had earlier on. Discontinue and look for secondary osteoporosis. This appears to be the majority. And I agree with this. Sandy, do you agree?
Yeah, I think I'd like to make a statement here that whenever this happens, the patient has a loss in bone density, I want to personally review those bone density tests. I want to look at the numerical data, the imaging, because often this is done at an off-site, a different site. And not infrequent, I see errors in positioning, analysis, and interpretation. And that changes the whole ballgame, as they say. So it's really important to review the DEXAs, because that's one of the most common reasons for confusion.
Absolutely. Any questions? Okay. So take-home messages, they're in your handouts. We're not going to go over. We've really discussed this ad nauseum now. Are you ready to move on to case 3? And I'm going to ask Dr. Boehm again to take over for a few minutes. Thanks, Andy.
All right. So case 3 is our 72-year-old female with QCT morphometric vertebral compression fracture diagnosed when hospitalized with pneumonia. She has a T-score of minus 3.6. at the vertebra. She is prescribed teriparatide daily, sub-Q. And so let's go to our first question. 6 weeks later, Mrs. C stops self-injecting because of nausea. What would you do? Teriparatide should be discontinued and replaced by antiresorptives, should be recommended to self-inject just before going to bed. Antiemetics, she should be told to tolerate the symptom, and in most instances, this will be self-limited. An ice cube placed in the mouth just before the injection should relieve the symptoms. Where did Ron come up with this? We have to ask him. So what do you think? Please feel free. Click or press your response. All right, so B is the correct answer. I certainly would be inclined to explain to the patient to do this in the evening, just prior to bedtime. Okay? She stopped self-injecting because she read about osteosarcoma. So now she stopped, and you have some choices. She should be reassured that osteosarcoma is not more frequent in patients self-injecting teriparatide than in the general population. Increased risk was only seen in toxicology studies when large doses were administered to rats that had not reached puberty. The risk of osteosarcoma is very small and greatly outweighs the risk of fractures. All right, we don't have enough people here to move on. All right, so as we talked about earlier, osteosarcomas occurred in these special rat studies before puberty. They were given multiple doses, very, very high doses, up to 60-fold the dose that is in humans. And they never it didn't close their epiphysis as part of this process. And they had many of them had, at this very high dose, had total osteosclerosis of their bones. And so this has never been seen in the 1 million-plus patients that have been treated with teriparatide. It has never been seen in severe primary hyperparathyroidism, which has 8-fold the usual serum levels of parathyroid hormone. And so I think it's really important for the patient to come in to see us and discuss this and to reassure them that this is not the case. And we can provide them with the medical literature in regard to this and explain that it just has never been seen in post-release of medical therapy, meaning after teriparatide was released at least 10 years ago. There's been post-release surveillance of the medication ever since. And there is no increased risk of osteosarcomas in these patients. Okay.
Where are people getting that information? Just
on the internet.
Well,
on the internet.
There's something, lawyers.
I can't tell you that. I don't know, but I can tell you that the patients that come in to see me.
It's not in the information they give from the
No, it is not. But it is a black box label, and so everybody's nervous when they see that, and we have to reassure them and provide them with the literature. I know that it's on the internet, and people are stating this. I can't tell you whether the attorneys that are malpractice attorneys are performing this function. Yes, please.
Did you choose teriparatide over an anti-resorptive just because of how low the T-score is, or was there some other reason?
I didn't choose it. Ron chose it. Sure, I choose teriparatide frequently in severe osteoporosis. In severe osteoporosis, I use teriparatide frequently. And the reason is because and plenty of studies have shown this, prospective trials, there's a delayed response of teriparatide when the patient has received 5 to 10 years of bisphosphonate therapy, long-term bisphosphonates. There's a delay. They will eventually respond, but you only have 2 years to respond, to take to provide the medication to the patient. So in that case, I would, if the patient had really low BMD and certainly had a fracture, that's severe osteoporosis, that patient would, from my standpoint, would be a candidate for teriparatide therapy initially, and then to provide them with a bisphosphonate or other anti-resorptive agent, such as denosumab after teriparatide.
The patient prior to this had had the fracture from twisting. She also had severe osteoporosis.
Sure.
So you could have chosen.
I could have chosen teriparatide. I use teriparatide frequently because I know it's very effective. And if you can accrue 10+% bone in 18 months to 2 years, and then add a bisphosphonate or denosumab, which could potentially accrue 6 to 8% in another 3 years, with decreased risk of vertebral fractures, 70% with teriparatide and 70% with denosumab or zoledronic acid, I think we're getting the most impact from our pharmacologic therapy. Okay. That's not what the insurance companies, by the way, want to hear, as you know. Okay. Mrs. C is self-injecting, has not experienced any problems, has not developed any ADRs, and is happy to continue. In 2 months, however, she's planning to go on a 3-week cruise in the Caribbean, followed by a 2-week stay in Aruba. Can she stop her medication? We should actually add another option. Who wants to go with her? All right, so the answer is no. I mean, basically, if she goes off for many weeks, she'll lose the effect, as we talked about. The effectiveness of the drug therapy is lost rather quickly. There are certainly, it's no different than taking your insulin as part of diabetes treatment or other medical therapies requiring injectables, and is totally permissible, whether you travel by air, by boat, or ship by any means. You could take a pack with you with a freezable insert into it, so it's like a portable refrigerator. While you're on the ship, you use a refrigeration system on the ship. So yes, I would take this medical therapy with me if I was the patient, and that's what I suggest. Okay. Mrs. C stopped because she cannot afford the copay at this stage. Another medication should be prescribed. Attempts should be made to find out whether she is eligible for financial aid. She should refer to social services, all of the above. And this is pretty common. This is commonplace. This is not unusual. People change their insurance plans. They have donut holes in their Medicare coverage. Wow, this is pretty interesting. This is almost psychotic. Are we done? Okay. So, oh, wait a minute, sorry. We're still moving in the right direction. So, first of all, before I consider another, and this happens all the time. So I just had a patient who lost coverage. The insurance company actually refused coverage, her new plan, and I had to write letters. I supported this, et cetera, and finally they did agree. Okay? It took quite a battle, but they did agree. So I certainly asked for help through my social services department, and whatever the patient can review on their own. I asked the company if there's a way of assisting the patient with financial aid. Whatever the case may be, I do whatever it takes to continue therapy if it's possible. It takes a lot of work, though, but it's in our patient's best interest. Yes, please.
Do you have samples of your or form letters that we could pass out to all of us?
Pardon me?
Do you have samples of your letters that you could pass out to all of us?
No, I don't. Because every letter is different. It is really very different. And I can't really, in the academic center, we cannot actually pass out samples either. So it's kind of a tough situation. But it's important to assist the patient in every possible way. And I would say 50-50 chance that the patient will be able to restart their medication. 1 year later, she's about to have a total hip replacement. Should she stop her medical therapy? Anybody want to vote? Don't be shy. Please proceed. All right, this was easier. So, teriparatide is an anabolic, as we talked about. It causes osteoblastic bone formation and stimulation of osteoblastic activity. And I use it as well as other physicians in non-healing, non-union of fracture. And so it actually has been shown, not in prospective randomized trials, but there is data that has been published with teriparatide showing that in patients that have non-union of fracture or non-healing of attempted surgical interventions and things of that nature, that it has helped in these individuals. And it certainly is not detrimental to fracture healing, so that I continue therapy throughout the period of treatment. Many of the neurosurgeons send me their patients for assessment of secondary etiologies prior to surgical intervention. Same thing with the orthopedic surgeons, because we know that many of our patients, at least 50%, have underlying additional secondary etiologies for their osteoporosis that should be addressed prior to surgery. And that's the best time to do it, prior to surgery. Yes, please.
Do you know if it's used for surgical fusions?
Not routinely. Not routinely. But in a patient with osteoporosis, though, who may have had a fracture or not, then what I suggest to the neurosurgeons and the orthopedic surgeons is have us evaluate the patient prior to surgery, give us time to assess the patient, and if there's a choice of the drug therapy that we have, then I would consider using an anabolic prior to their major lumbar spine fusion surgery or their total hip surgery in a severe osteoporotic, then a bisphosphonate. I would go with an anabolic first. Yes, please.
Any reason to stop, do anything with your bisphosphonate, either around time of surgery or making a fracture?
So the question, if everyone has not heard, is whether you stop a bisphosphonate prior to surgical intervention. And there's no data to show that it impedes healing post-operatively. Matter of fact, the study that was done showing that zoledronic acid reclass 5 milligrams infusion just after hip fracture and repair showed no altered healing in those patients. In the original FIT trial, that's the alendronate trial, placebo group versus alendronate 10 milligrams a day. In those patients, they actually looked at the patients on alendronate who had a Colles fracture. And they followed these people radiographically for fracture healing on alendronate. This was part of the trial. And they found that there was a robust callus formation that occurred during the process of healing. It was much larger than they usually see. There was a slight delay in the complete healing, but there was no abnormality in healing of that fracture. Yes, please. One over here. This lady here.
Yeah, if you have a fracture that's like a non-union, 3 months out, you stop seeing any healing, can you stop it?
Do you stop what there? Well, I think the issue is the patient's been on it's no different than anything else. The patient's been on a bisphosphonate for 5 years. Is it going to make any difference physiologically whether you stop it or not in the serum level? Answer is no. There will be recirculation of bisphosphonate. So what I would do, my personal clinical judgment would be to assess that patient. If it wasn't my patient and it has been referred to me, I would assess that patient for underlying etiologies for non-union or non-healing or delayed healing. And not infrequently, I find other etiologies, as I mentioned to you with some of those patients that have iatrogenic hyperthyroidism. I have one patient who had normal total serum calcium, but had exceedingly low albumin, and with a corrected calcium, had hypercalcemia for years, 12 years. Okay, so the patient's walking around with primary hyperparathyroidism, never diagnosed because it wasn't flagged on a chemistry panel, because no one corrected the total calcium for albumin. So what I'm saying is it requires investigation. We're all detectives. We're all detectives, and we have to use our acumen to determine what potential etiologies are present in those patients that have non-union or delayed healing. And it's not infrequent that we find that. They may be smoking, they may be drinking, they may be carrying on like lunatics, who knows what. But what I'm saying is that there are other reasons commonly found as an etiology. Okay, let's go on. On completing the 2-year course, the patient is asymptomatic. Anti-resorptive therapy should be initiated as soon as possible. There is no need for any therapy. A DEXA scan is recommended now and in 2 years' time. All right. And so as we talked about previously, once you discontinue teriparatide therapy, over a period of time you will lose the benefit in bone density as well as fracture risk reduction. So it's essential to discuss this issue with the patient prior to discontinuing teriparatide therapy, and then make the most appropriate decision based on the individual patient of which anti-resorptive therapy should be considered in that situation. And every patient is individualized based on cost of medication, absorption of medication, whether the patient has dementia or other problems that will require thinking out of the box specifically for that patient. Now, the other thing is, at the time of discontinuation of medical therapy, I'd certainly want to do a bone density test to have that new base before I start a new medical therapy, because you're going to be reaching a peak of the medical therapeutic intervention at that time after 2 years. So then you can have that new baseline before starting an alternative therapeutic intervention. The BMD of the lumbar spine and total hip have increased by 7% and 6% respectively. The BMD of the distal radius, however, has decreased by 5% at this stage. So again, this is a patient on teriparatide, and we see that at the forearm, at the distal radius, 33%, there is a change in bone density, but not in the direction we would like. She should be investigated for secondary osteoporosis. There is no need for any intervention. A repeat DEXA scan is recommended in 2 years' time. An anti-resorptive agent should be prescribed. Anybody else? So I think the majority of individuals would select there's no need for intervention. She's received 2 years of therapy, repeat DEXA, and anti-resorptive prescribed. So it's not unusual to see in individuals at the forearm a stable, no increase in bone density on teriparatide or a slight decrease in bone density. This doesn't mean that teriparatide has failed to accrue bone density, but it's sometimes seen in cortical bone, including at the total hip and other regions that you measure, not at the spine so much, that there is stable or slight decrease in bone density. And this could be the increased bone turnover that's occurring, the delay in mineralization of bone, other factors that delay the full effect of bone accrual. But it doesn't mean that the drug has failed in this patient. So I would not be significantly concerned at the distal radius per se, unless the patient had immobilization or some other condition at the distal radius. The patient should be prescribed an alternative medical therapy. Again, I would do a baseline bone density, as has been done here, and move on to additional anti-resorptives. So our take-home message, teriparatide is prescribed for 2 years. At the end of 2-year course, an anti-resorptive should be prescribed to maintain or increase bone mass. Okay. Randy, what time is it? Randy?
15 minutes.
15 minutes? Okay. How's everybody doing? Okay? You tired? Is everybody tired? Yes, everybody's bobbing their head, yes. Can you deal with 15 more minutes of me? Okay, all right. So let's go on to case 4, and then we'll quit at about 15 minutes, if that's okay. Unless everyone wants to have dinner together, and we'll keep on going. Okay, so we'll go to our next case 4. Mrs. D, she's the patient who had a Colles fracture 3 weeks ago. She was referred to the orthopedic surgeon. She had surgical menopause at 35. She had endometriosis, no HRT, asymptomatic, sedentary lifestyle. She's the one, remember we talked about how she consumed all the coffee. She also had a lot of soda and 1 martini, 2 glasses of wine, and had osteopenia by bone density testing. So, 8-week contact. Mrs. D is taking the medication. She was prescribed raloxifene in this case. Okay? And there's no adverse effects. She's happy to continue taking medication at this time. She should be encouraged to continue raloxifene. Follow-up contact should be made in 6 weeks' time. A follow-up contact should be made in 6 months' time. A follow-up contact should be made in a year. Please choose. right. I think most people would suggest that she should be encouraged, that this is good. She hasn't had any major side effects or adverse reactions, and that she should return in approximately a year. Others would, like Dr. Hamdi, who has nursing.
Should I leave again, or?
Could you please? Oh, yeah. Oh, there you are. Has a nurse who would call, if you have a nurse, or if you have time, you would call the patient. I would call the patient 6 months into the treatment to be absolutely sure the patient is doing well. It never hurts. Okay, in this case scenario, the patient is developing hot flashes, hot flushing she cannot tolerate. She should be recommended to take raloxifene before bedtime. It should be discontinued. She should be referred to a gynecologist. She should be encouraged to tolerate this adverse event as it's usually self-limited. A beta blocker should be prescribed. So one person believes it should be discontinued. Okay. So I think that the majority of individuals who have voted believe that the patient should be encouraged to tolerate the symptom, and it's usually self-limited. How many of you voted this way? Raise your hand. How many of you used raloxifene? So those of you that have used raloxifene believe that this is self-limited, correct? And that's what I've seen also. I would certainly suggest at bedtime dosing as well, and then come in to talk to me if there's continued evidence of this. Would you use anything else, Ron?
No, I just brief note. I wouldn't go for a beta blocker. We don't like, as a routine, to prescribe a medication to counteract the effect of another one. So if they're not self-limited, maybe it's time to consider giving her something else.
And I think that it depends upon the degree of hot flushing the patient has. If it's tolerable, let's see if it resolves over a period of time. If it's impossible to tolerate, I think we need to reconsider. Okay. She's about to undertake a trip to India to visit her son. She plans to stay there for about 2 weeks. So what should we do? Should raloxifene be discontinued at least 2 weeks before flying? Should she be prescribed aspirin? Should she wear elastic stockings while on the plane to Japan? So we didn't get to India.
She's doing a side trip to Japan.
Again, I just want to mention to everybody that I didn't come up with this question or these options.
It's a tricky question.
This is a tricky one. He was trying to trick you. I'm glad it wasn't Afghanistan.
She didn't want to disclose the exact itinerary.
She wanted to see her son in ISIL. Okay. So we're almost there, I think. I mean, come on, let's people vote. Let's see what everybody thinks. We're too tired to. Okay, here we go. All right. So as we talked about, there is this increased risk of DVT, as in the same cases, any hormone therapy, estrogen therapy. And so it's really important, as suggested by the manufacturer, in understanding this, that the patient discontinue the medical therapy a number of days before the flight, to wear elastic stockings, and then to restart if they're going to be in the country for an extended period of time. If they're only going for a couple of days to India or to Japan and then India, then it would not be worth restarting because they're going to be on the flight back. Okay? Any questions about that?
What do you think is half-life of relaxant?
It's a couple days out of your system. It's 5 days, I think, out of the system, something of that nature. I think the manufacturer in the PDR says 3 days to be off of it prior to the flight. But I think I would go with the 2 weeks if I had a choice. Raloxifene should be, the patient's about to have a cholecystectomy. Raloxifene should be discontinued at least 2 weeks before surgery. She should be prescribed aspirin. She should wear elastic stockings. Oh, my. Okay, so what do you think? Same scenario. The patient's going to be incapacitated as part of surgery. Do you want to discontinue therapy or not? All right. So I think that the prudent thing to do would be to discontinue therapy prior to surgery. I think that's the main issue here. Okay? Raloxifene increases the risk of DVT by about 3-fold, similar to estrogen therapy. It should be discontinued and the patient participate in a long period of relative when a patient is going to be immobilized for whatever reason. Okay. Case 3. Oh, are we okay, or should we? 7 minutes? Okay, 7 minutes it is. All right. So let's continue. This is case 60. This is case 5, 68-year-old, asymptomatic, T-score minus 2.8. DEXA scan was done as a routine. Laboratory tests are normal. Negative family history. She's prescribed denosumab. So she should be, the patient does not want to take the medication because of the flatulence it has caused. She should be told to take simethicone tablets. She should be told that on balance, the risk of flatulence is greatly outweighed by the potential benefit of the medication. She should be reminded of her risk and potential impact of sustaining a fracture. Denosumab should be discontinued and a note made in her records. She should be invited to attend the clinic to discuss her concerns and other treatment options. All right, so everyone wants to talk to the patient. Ron, what do you think? What would you do in this case scenario?
I would invite her to come back to the clinic to talk about it. And usually the outcome, I've come across about half a dozen patients with this problem, and then they usually respond very well to simethicone. For whatever reason, the flatulence doesn't appear until about 2 weeks after the injection. It's usually self-limited to about 2 weeks, and it responds very well to simethicone tablets.
Okay, very good. She does not want to have a second injection because she heard that it causes the risk of infections. She should be told that the risk of infection is not increased and that she should get her second injection. Denosumab should be discontinued and a note made in her records, the same sort of scenario. Another medication. She should be invited to attend clinic to discuss her concerns. She should be told that on balance the risk of infection is greatly outweighed by the potential benefit of medical therapy. All right, so I think I would agree with this in that I would invite the patient back, explain the data, meaning the increased risk in the initial freedom trial that was not substantial. First of all, these were cellulitis cases. They had no relationship to the injection per se, meaning the timing of the injection. They were not at the site of injection. That unless the patient was immunosuppressed or had some other issues, I would reassure the patient, and with that discussion, hopefully the patient would continue her medical therapy. Okay? Any other comments, Ron? Okay. She wants to postpone her second injection because she's getting married and is concerned about flatulence.
That's a true case.
You didn't make this up, did you? He made this up. No.
No, actually, it's the past 2-3 weeks before coming here.
Okay. She wants to postpone her second injection for at least 3 months. Okay. The injection should be postponed. She should be told that it's very important to take the medication, and her spouse should understand the situation. This is a good test for a marriage, right? This is really important. Are we on the same page here, honey? Should she be reminded of her risk and potential impact of sustaining a fracture, or B, C, and D? I can't wait to hear Ron's response. Go see a divorce attorney first.
No. Actually, I recommended that she postpone the injection for 3 months. Okay. I felt sorry for the husband.
Okay, so most of the folks here believe that it's important to take the medication, that she should be told to take simethicone, and then reminded of her risk. Okay. I think I would go with that, and if she still refuses, that's her option, of course. I like this. What did the patient eventually wish to do?
She didn't want to take it she said she's not going to take it anyhow, no matter what I said. But she's letting me know that that's what she's going to do.
Okay. So you said, I still love you. We'll come back afterwards. Okay. She does not want to have the second injection because she heard that it may cause her jaws to rot. And the probability of developing ONJ should be compared to that of developing sustaining an osteoporotic fracture. She should be sent to her dentist to make sure her gums and dentures are healthy, and no invasive dental implants are anticipated. Denosumab should be discontinued and note made in her chart. She should be told that no case of ONJ ever reported with denosumab. Okay. What do you think? Only 9?
11.
I see the problem with A and B is that you're kind of contradicting yourself. You're saying that without any increased risk, you better go see your dentist to make sure you're not going to have anything done. But you're saying, well, there's not really any increased risk. There's very little increased risk.
Mm-hmm. So first of all, looking at D, that's incorrect. So she should be told that no case of ONJ has been reported with denosumab, and that is incorrect. There have been cases reported. And this is an extension trials going from placebo to treatment, and certainly in denosumab treatment of skeletal-related events, when patients are taking double the dose, not 60 milligrams Q6 months, but 120 milligrams of denosumab every 3 to 4 weeks, this has been seen. Okay? So it does occur. Should it be discontinued? Well, I think we need to sit down with the patient and negotiate with the patient and explain that it is a rare occurrence, that if we had done our due diligence initially, she would have seen her oral surgeon before we even started it, okay, before the first injection, that there was no change in her dental hygiene, that she is seeing the dentist every 6 months to be sure everything is normal. And that's how I would approach it. Ron, anything?
I agree.
Okay. And then she does not want to take the second injection because she heard the risk of atypical femur fractures.
Same.
Same thing. And I think we would discuss the same situation. We would bring her in and explain to her that the risk of fracture is so much greater than after one injection of denosumab that she should continue this therapy because of that. It's a rare condition, and certainly after one injection it is not seen. But we should reassure the patient because the risk of fracture in her case, is so much greater than the risk of atypical femur fracture. Okay? All right.
I agree.
All right, if there are any questions, please feel free to come on up afterwards. We're here now, we're here tomorrow, we're here the next day together, and we're here together to work together on this program. Thank you.
Good job, Sandy.